Yes, ma'am. We can start, ma'am.
Yeah. Thank you. Thank you, Shiraz. Very good evening to all my seniors, all AHD members, and Dr. Naba. I'm audible.
Yes, ma'am. You are audible, ma'am.
Okay. Very good evening to all my seniors, all AHD members, and Dr. Naba. It's my pleasure to meet you all once again on this platform. Namaskar. Myself is Dr. Sushma Trivedi, working at NHPC as a pediatrician, and also I'm a executive committee member of AHD Delhi branch. It's a great today being a part of webinar, and I believe this session is going to be a very interesting session for all of us, as we all are always interested and looking forward for such type of webinar, which is based on newer and advanced medicine and advanced modality of treatment, especially in the field of oncology, which is the topic is today related to onco. And I think no one is better to speak at this than Dr. Naba. Today's topic is HPV negative oropharyngeal cancer, prognosis, treatment, and perspectives. I'm sure this will be a very interactive session. Without further ado, now would like to introduce Dr. Nava Kumar Kalita. Welcome, sir. He has done MBBS, MD, and fellowship in clinical oncology, working as a consultant oncologist at State Cancer Hospital, Guwahati. Dr. Nava has presented and published more than 9 scientific papers in national and international journals and given presentation in many conferences. He has experience of working in State Cancer Institute, Guwahati, Assam for more than 5 years. He has participated as a guest lecturer on preventive oncology at Mangaldayi in 2018. Dr. Nava has presented various talks, seminars, mini teaching, and micro teaching on various topics related to medical oncology, molecular diagnostics, medical genetics, immunology, metabolic disease, molecular and clinical biochemistry, onco biochemistry, etc. at SCI and intra-college level. Dr. Nava has participated in various journal clubs held on recent biochemical markers in different diseases, etc. at intra-college level. Thank you, sir. You are most welcome, and you can start your topic. We are waiting for your lecture or presentation.
Thank you, ma'am, for your kind introduction. So it's a pleasure for me to come here and talk about some very important topic related to all of us. And thank you to Biocon once again for allowing me to speak on this very important topic. So today the topic of discussion will be the HPV negative oropharyngeal cancer, its prognosis and treatment perspective. Hope I am audible to all.
Yes, sir. You are audible, sir.
Yeah. So you can go to next slide, please.
Shivans, I am audible.
Yes, ma'am. Sir is audible, ma'am.
And I'm also, no?
Yes, ma'am. Yes, ma'am.
Whatever I read, that was audible because I
yes,
was on
ma'am.
mute. Okay.
Yes, ma'am.
Thank
Yes,
you.
ma'am.
Thank you.
Yeah. So regarding about the Globocan data of regarding the epidemiology of head and neck cancer, so it's ranked among the various cancer. It ranks 25th actually with the number of new cases, 98,412, and number of deaths is almost very good number, 14,143, and the incidence rate 5 years prevalence rate actually, it is about 3.32 per 100,000 population. Next slide.
Who is changing this slide?
We can go to next slide. Yeah. So regarding the risk factor that is associated with the head and neck cancer, we know that it is very much preventable with some risk factor involved with both. We know that the tobacco and alcohol are the prime factor that is associated always with the oral cancer. So it is mostly prevalent in India, in the rather than the Western countries. So we should look about it regarding the preventive oncology has to be very much stringent. How to avoid all this occupational behavior so that we can avoid from getting the head and neck cancer, because most of the cancers are preventable. Apart from that, the HPV-16 and HPV-18 virus association is very much there. We know that though in India the number is less than 20%, but it is one of the factor that is commonly associated in the Western population. And apart from that, the betel nut that is commonly prevalent in Northeast India, in other parts of the country is always associated with, that is the smokeless tobacco SLT, which is very much associated with head and neck cancer. And apart from that, the exposure to radiation with the A's and the ultraviolet rays are very much associated with the head and neck cancer. These are the prime factor there, or the risk factor that is associated with occurrence of head and neck cancer. Next slide. Talking about the various challenges and regarding the management of locally advanced oropharyngeal cancer, mainly we are talking about, because most of the patient, almost in our setup, almost 70 to 80% of the patients actually comes to our OPD at a very advanced stage. So the management of locally advanced oropharyngeal cancer and regarding all head and neck cancer, so the management is very much difficult because it poses some challenges due to the anatomical location and the physiological function, where the nutrition of the people are not good. People cannot eat, and so the people comes or the patient comes in a very poor performance status where uh, so palliative treatment is the option that remains is almost 50% of the patient. So it's a matter of concern for all of us then how the patient can be brought to an early stage so that some effective treatment can be given. And regarding uh, the unique challenges that it poses due to some anatomical location where the surgical access can be difficult. Of course, the surgical in localized cancer, it is very much accessible, or we can say very much surgically manageable. But in advanced setting where the surgical resection may be difficult due to the anatomical location, and the concurrent chemoradiation is most of the options we have left apart from the surgical therapy. And the prognosis also depends on the HPV status. And we know that the HPV positivity, it gives a favorable prognosis. And regarding the HPV positivity disease, the India that we have already mentioned, so reported for 15 to 22%. So we can say that less than 20% of the population are HPV positive. So the rest 80% are where the prognosis is very much guarded, and on the top of that, the people comes in a very advanced stage where the definitive treatment can uh, is a distant dream for the patient. Next slide. So regarding the concurrent chemoradiotherapy or concurrent CTRT, apart from the surgical perspective, what we have option is the concurrent chemoradiation. So what are the outcomes that let's revisit the slides. Next slide. This is the trial of phase 3 randomized trial of Fallenstein DZ et al. So he has stated that the 5 years of overall survivability of radiation versus concurrent chemoradiation. So in that study, the oropharyngeal cancer. He has taken 22% of the patients, and in two arm they have given RT alone. So the radiotherapy can be 66 to 72 gray in conventional 1.8 to 2 gray per fraction. And in other arm, they have used concurrent chemoradiation, where they have used cisplatin plus 5-FU 3-weekly regimen that we commonly use, and also we use weekly cisplatin in some of our patients. And after the definitive chemoradiation, if there is some residual or recurrence disease, then the surgery can be one of the options along with the neck dissection. So in that population, they have found that the 5 years overall survivability with the concurrent chemoradiation is 50% versus 48%, and the recurrent-free survival is 62% versus 51% in the RT alone group. And distal metastasis free survival is 84% versus 75% in the RT alone population. Overall survival with the primary site preservation is 42% versus 34%, and the local control without resection can be 77% in the concurrent chemoradiation arm versus 45%. So, giving the concurrent chemoradiation definitely gives a better survival benefit and a better local control. And if the patient can be, if after residual or recurrence, if the surgical option can be given, then the local control is very much there, seen by the data that is presented. Next slide. So this just they have used the Cox regression analysis of the overall survival with the primary site preservation. They have seen that the oropharyngeal versus hypopharyngeal. So it is statistically significant, be it a univariate analysis or multivariate analysis. Next slide. So what are the options for outcome with the sequential chemoradiation or induction chemoradiotherapy? Can we use the induction chemoradiotherapy in locally advanced head and neck cancer? Next slide. So sequential chemoradiation therapy or the induction chemoradiotherapy, so it is associated with the survival benefit and could be an valuable treatment options. This is stated by the Wayne State University regimen that is commonly used in various parts of the country. That is 5-FU 1000 mg per meter square for day 1 to day 5, and cisplatin 100 mg per meter square in day 1. So very toxic regimen. And other option we have is the TPF that we commonly use, but it is also associated with a lot of toxicity, neutropenia, and one of the regimen is the TEX 3-3 study, where they have compared the TPF with the PF, that is the 5-FU plus cisplatin regimen versus TPF. So addition of docetaxel along with the 5-FU cisplatin. So triplet versus dual chemotherapy combination is if they give any survival benefit or not. Let's find out. Next slide. So this is the URTC 24971 study, text 32 study, 323, very popular study. So in the inclusion criteria, they have used from 18 to 70 years population, unresectable squamous cell carcinoma of the head and neck region, stage 3, stage 4, where upfront surgery or upfront chemoradiation can be difficult sometimes. With a good echo performance status, and the patients with nasopharyngeal carcinoma and the nasal and paranasal cavities tumors were excluded from the study. From the population, we have seen that almost 46% of the populations they have taken were from the tumor originating from the oropharyngeal or oropharynx. And the arm was evenly distributed, randomized into 1:1 arm. In one arm A, they have used the TPF regimen, that is the docetaxel, cisplatin, and 5-FU triplet chemotherapy arm, and the arm B, they have used the conventional 5-FU and cisplatin. So addition of taxanes is there any benefit of adding the docetaxel with the conventional doublet chemotherapy, followed by the neck dissection and the radiotherapy and surgery for the residual disease? and they have found that, next slide. So in case of progression-free survival, so there is an survival benefit in terms of progression-free survival. So the median progression-free survival is 11 months versus 8.2 months, with a good hazard ratio 0.72 and statistically significant p-value. And a PFS benefit that is observing irrespective of after the data cap of 3 years, we have seen that the PFS benefit is still there with the triplet regimen. So, if the patient is fit enough, if the performance status is good, so always we should go for the triplet chemotherapy based regimen based on this trial. And we are also doing the same in our setup also if the patient is physically fit enough. So we generally go for TPF induction chemotherapy. Next slide. Regarding the overall survival benefit, so we have seen that it is equally supportive. That is, the TPF triplet chemotherapy combination gives a median overall survival of 18.8 months versus 14.5 months with a good hazard ratio 0.73. Next slide. So to conclude, we can say that the concurrent chemoradiotherapy has newly replaced the radiotherapy alone. So the dual modality of treatment is always better, where the patient can be treated with dual modality treatment in unresectable squamous cell carcinoma of the head and neck. And TPF regimen, though it leads to more leukopenia and neutropenia, but did not need to more frequent infection when the patient received the prophylactic antibiotics, and TPF led to fewer treatment delays and was associated with fewer deaths from toxic effect. And PF regimen was associated with more grade 3 and grade 4 thrombocytopenia, nausea, vomiting, and stomatitis. So in summary, you can say that the triplet chemotherapy combination can give us a better progression-free survival and overall survival. Next slide. What are the outcomes about the targeted therapy? What about the targeted therapy? So we now have made very much option, especially in head and neck cancer. We have the biologicals and the maps that is available with us. So presenting from the data that most of the head and neck cancers are EGFR receptor positivity is very much associated. So you can see that the EGFR positivity, so we have used the anti-EGFR drug in especially in pancreatic, renal carcinoma, breast carcinoma, ovarian, glioma, and bladder. So in all these cancers, we have seen that the EGFR positivity is there, but in head and neck cancer, you can see that it can be as high as 80 to 100%. So seeing the data that most of the head and neck cancers, squamous cell carcinoma, are EGFR responsive. Next slide. So EGFR overexpression is correlated with the poor prognosis. We can see from the data that tumor overexpressing EGFR demonstrated a lower local control after radiation therapy, and 5-year survival rate is 81% in EGFR non-expressing tumor versus 25% in EGFR expressing tumor. And also the multivariate analysis has stated that the overall survival and the disease-free survival and the locoregional relapse is very much associated with EGFR positivity. Next slide. Regarding the cetuximab and concurrent chemoradiotherapy, there is some trial to show that in our TOG0522 trial, there is a phase 3 trial, which have stated that there is no improvement in the overall survival and the progression-free survival, whereas in the Mariano et al. Trial, in phase 2 trial, they have seen that there is PFS and overall survival advantage. So the conflicting results are coming from various trials. Next slide. So regarding the bonus trial, this is the landmark trial about cetuximab along with the radiotherapy. Those patients who was not cisplatin ineligible. So those patients were randomized into 1:1 arm, and they are given the options of either radiation alone or 6 to 7 weeks of radiotherapy plus weekly doses of cetuximab with a loading dose of 450 mg per meter square and a maintenance dose of loading dose of 400 mg per meter square. Next slide. Yeah, regarding the overall survival benefit, it is very much associated. So the bonus trial has seen that there is significant overall survival benefit by using the biological along with RT compared to the RT alone group. They have we can see that the graph is really separating, and there is a clear benefit of overall survival. Next slide. Regarding the nemotuzumab data, this is the only anti-EGFR providing a better data compared to the chemo radiation and can be given with the chemo radiation. So mind you that the nemotuzumab, it can be given along with the cisplatin and the cetuximab, where they have used the cisplatin ineligible patients. So there is a data. So what is nemotuzumab? It's a monoclonal antibody, humanized IgG1 isotype, and with a bivalent binding to EGFR. Next slide. So this is the TMH study. So what they presented in the ESPO. So this is all about a randomized phase 3 trial comparing the nemotuzumab, which is a biological, plus cisplatin in the chemo radiation. So that is the chemo radiation in addition with biological versus cisplatin and radiotherapy. So that is the conventional chemo radiation arm that we commonly use in our practice in head and neck cancer, in locally advanced head and neck cancer. So addition of biological along with the cisplatin, will they give us any benefit? So the trial is all about that aspect only. To inclusion criteria, patients more than 18 years, newly diagnosed, treatment naive, stage 3 or stage 4, locally advanced, non-metastatic, and with the disease in the oropharynx, larynx, hypopharynx, or oral cavity with a good performance status and adequate organ functions, were included the patients with the nasopharyngeal or salivary gland tumor and prior treatment with the radiotherapy or immunotherapy. Those patients were excluded from the study. It was a 1:1 randomization. In arm A, they have used a fixed dose of nemotuzumab 200 mg along with the cisplatin 30 mg per meter square every weekly along with the radiation, that is 70 gray in 1.8 per gray per fraction. And in arm B, they have used the conventional radiation along with the cisplatin 30 mg per meter square weekly doses, and cycles were continued till 7 cycles were allowed along with the radiation. Next slide. So the primary endpoint was to see for the progression-free survival, and the secondary endpoint was to see for the disease-free survival of original control, overall survival, treatment compliance, adverse events, and the quality of life. Next slide. So regarding the oropharyngeal cancer, almost 50%, more than 50%, you can say that almost half of the patients were taken where the disease in the oropharynx. And stage 4A, so nodal burden or locally advanced disease. So we can see that almost 2/3 of the patients were very much locally advanced, where the T4 and 3 disease, so where the treatment is very much guarded. So those patients were included in their study. Next slide. So regarding the completion of the chemotherapy cycle, evenly matched in both the arm, almost more than 80% of the patients could complete mandatory 7 cycles, and some patients could not complete due to some complications, but it was evenly matched in both the arm. Next slide. So regarding the PFS, what was their primary endpoint? So PFS was found to be significantly longer in patients receiving the nemotuzumab chemotherapy radiation arm. And the cisplatin cumulative doses were more than 200 mg per meter square And regarding the uh, progression-free survival, it was very much there with a nemotuzumab arm compared to the conventional chemoradiation arm. And 2-year progression-free survival, we can see from the graph that it was 61.8% in the nemotuzumab arm versus 50.1% in the chemoradiation arm, with a good hazard ratio 0.69 and a p-value. So the primary endpoint they have achieved, so 2-year disease-free survival and the progression-free survival is statistically significant. We have to wait for some other data, maybe after 5 years, so we can have another good robust data. But let's wait for this data to mature. But the 2-year progression-free survival is very much encouraging for us. Next slide. So we can see from the progression-free survival data that addition of the nemotuzumab led to consistent benefit across all the age group, irrespective of the age or size or the stages uh, or other radiation techniques. So irrespective of all the subgroup analysis, they have seen that addition of nemotuzumab leads to better PFS in all the subgroups. Next slide. And regarding the secondary endpoint, that was the disease-free survival, we can see from the data that the disease-free survival after 2 years is 60.2% in the nemotuzumab arm versus 48.5% in the chemoradiation arm. So definitely with a good hazard ratio of 0.71, so that means that it decreases the hazard of disease recurrences by 29% in the nemotuzumab arm with a good p-value. So disease-free survival and the progression-free survival is very good, more than 60% versus 48% in the sorry, chemoradiation arm. Next slide. This is regarding the local regional control, which was their secondary endpoint, one of the secondary endpoint. We can see from the graph that the local regional control at the end of 2 years is 67.5% in the nemotuzumab arm versus 57.6% in the chemoradiation arm, with a good hazard ratio 0.67. Next slide. Regarding the overall survival, it is also very much with the nemotuzumab arm. We can see from the data that the 2-year overall survival data 63.8% versus 57.7% with a good hazard ratio 0.84, so fairly good enough. And in both the arm, patient has received the cumulative cisplatin dose of more 100 to 200 mg per meter square, which was taken as a standard for head and neck cancer. So both the arm were evenly matched with respect to the cisplatin dose. So from this data, we can say that addition of the nemotuzumab along with the chemotherapy can give us a very good progression-free survival, overall survival, local regional control. So data is very much promising. Next slide. Regarding the radiation compliance, so you can see from the data that it is evenly matched. So radiation compliance was very much there, and addition of the nemotuzumab did not lead to any incremental increase in the radiation toxicity. We know that the EGFR anti-EGFR drugs are very much associated with skin reaction, but in the study they have found that almost more than 94% in the in the cisplatin radiotherapy and 93% almost evenly balanced. So this much a patient can put to the 100% of the planned radiotherapy doses. So there was no any hampering, or there is no any treatment delay due to the use of nemotuzumab. Next slide. Chemotherapy compliance was almost evenly matched in both the arm, and we can see that the compliance of the chemotherapy was there in both the arm, irrespective of whether we have used nemotuzumab or not. So addition of nemotuzumab did not lead to decrease in the compliance of chemotherapy. Next slide. So this subgroup analysis of nemotuzumab phase 3 study of especially about HPV negative oropharyngeal cancer. So we can see from the data. Next slide. So it is even more beneficial, especially in the HPV negative. You can see from the data that 2-year progression-free survival is with 57.2% versus 31.5% with concurrent chemoradiation arm, with a 25.7% increase, and the 2-year local regional control percentage is 60.4 with the nemotuzumab arm and 41.4 with concurrent chemoradiation, with an increase of the value of 19%. And 2-year overall survival benefit is 57.6% in the nemotuzumab arm versus 39% in the concurrent chemoradiation, with an increase of 18.6%. So addition of nemotuzumab, especially in the HPV negative oropharyngeal cancer, so result is even more promising. Next slide. And so from this study, you have found that we have already mentioned 2-year progression-free survival benefit by 25.7%, with a decrease in the hazard ratio progression by 46%. 2-year local regional control was increased by 19%, with a decrease in relative risk of local regional failure by 39%, and 2-year overall survival benefit by 18.6%, with a reduction in the hazard rate by 37%. So HPV negative oropharyngeal cancer, where the prognosis is not so good. So even in that category, they have given us very good benefit. So this is all about we have already mentioned. Next slide. Regarding the mucositis, so it is one of the commonest complications receiving the anti-zipper drug. So you can see from that the mucositis is evenly matched in both the arm, be it a chemoradiation or nemotuzumab arm, almost 96% versus 97%. But the grade 3 to grade 5 toxicity is little bit higher on the nemotuzumab side, 66.7% versus 55.8%, and the grade 3 to grade 5 p value. So this mucositis is a bit concerned, and it is found to be statistically significant. So grading of mucositis 3 to 5 with the nemotuzumab arm. So we have to be a little bit cautious, and we have to look for the adverse events. Other than that, the radiation, dermatitis, or rhinophagia, nausea, vomiting, weight loss is very much similar with in both the arm. So so we have to be aware of all these adverse events while prescribing the drug. Next slide. So regarding this is about an Indian clinical practice consensus guideline for head and neck cancer in the oropharyngeal cancer. If in the loco-regionally advanced that we are discussing today, so locally advanced oropharyngeal cancer, T3, T4, or N2, N3 disease, if it is a P16 HPV negative, so concurrent chemoradiation with the nemotuzumab is category 1 recommendation from Indian guideline, and so it's all about the Indian population, and so it's a very good Indian data to use in our population. So where the HPV negativity patients poses a bad prognostic indication, but in that population also the nemotuzumab can give us a very good progression-free survival, overall survival, and the local control. Next slide. So for the management of oropharyngeal cancer, stage 1 and 2 oropharyngeal cancer, we all know that that the surgery is one of the valid options. So, but however, the radiation seems to be the preferred option if the single modality is used. In stage 3 or stage 4, where it is a loco-regionally advanced, In cisplatin fit patients, we can go for radical chemoradiation, that is radiation along with the weekly cisplatin along with nemotuzumab if the patient is fit enough to receive. If the patient is cisplatin unfit, then we can go for some some radiosensitizer agent like 5-FU carboplatin along with radical radiation, or we can use the cetuximab or nemotuzumab if the patient is affordable. Next slide. So that's all that we have to discuss. Thank you for your patient listening. Thank you.
Thank you, sir. Thank you, Dr. Nava, for the wonderful session. It was really very interesting and very informative session. I think this topic is quite new. It's not very new, but it's a little bit, it's a queue for quite new for a few cities where this modality of treatment is not available readily. And it's an upcoming modality of treatment and also very important to understand for the current scenario, where to give, how much it is effective, and it's a cost effective point of view also. So there's lots of things we have to think about this treatment. You have told so many things about the nimetuzumab and all. So it's a really very informative, and thank you very much for that. I cannot see any question in the drop box. Mr. Shivans, is there any question?
No, ma'am. There is no question in the Q&A box, ma'am.
So, Dr. Nava, I am having few queries after your presentation, wonderful presentation. I'd like to ask you a few questions. My first question is, what is concurrent chemotherapy and its outcome?
In locoregionally advanced cancer, in our setting, frankly speaking, the recurrence is within 2 years. We have seen after the definitive chemoradiation. So in locoregionally advanced disease, where the 5-year overall survival is also not so high. So we are seeing the recurrences within 2 years. So most of the patients, almost 60 to 70% patient recurs within 2 years. And even we are getting the recurrences or the relapses within 6 months also. So that is the scenario. So head and neck cancer is so the prognosis is not so good in stage 3 and stage 4. So and the locoregional control is very much, it should be our priority, and the primary treatment has to be very good. So if we can add some biological agent along with the concurrent chemoradiation arm, so that is very much helpful, though not only to give them a good overall survival benefit and also some locoregional control and the progression-free survival. So of course the cost factor is also a bit of worry for some patients. We know that we also work in a government setting, so know the limitation, and the patients generally comes from a poor economic background. So the government of Assam has extended the benefit. It is available from the state government. So we can use from our patients. We are using it regularly where the patients can be used. If the patient is fit enough to receive the cisplatin originally, and especially in oropharynx, we are using to very much extent. We are getting good result also, no any other toxicity. And we are also conducting one similar study to see what is their disease-free survival and locoregional control after 1 year. So hopefully we'll be able to publish the data in the next year. So we are very much looking forward to our data, so apart from the PMH.
Okay. So, and the second question, what is targeted therapy and outcome, and how to identify specific therapy? During what condition, what stage?
Yeah, so regarding the conventional chemotherapy, we know that it is very much toxic. It is associated with some adverse events, and the targeted therapy is that so where the patient is not eligible to take the systemic treatment like chemotherapy, or especially in lung cancer also, we can see from the head and neck or lung cancer where the EGFR expression is so much high. Even in lung cancer also, so anti-EGFRs are very much used. So it is very much common that we get EGFR positivity or L positivity, where we can use the targeted agent. So it gives a very much good advantage over conventional chemotherapy, that the side effect profile is very much less. So the patient compliance is very much there, and the treatment can be extended to a prolonged period of time. Unlike the systemic therapy or the chemotherapy, we have to stop after some cycle, 6 or 8 cycle, because we cannot go on like that. But the systemic therapy, but the targeted therapy, the advantage is that it can be extended for a prolonged period of time, because of the because the toxicity profile is very much less compared to the conventional chemotherapy. So it gives a very much advantage of where the patient can be benefited. So we should and we must use targeted therapy.
Okay. And what are the challenges you are facing during the management of the patient, during the giving treatment, like whole chemotherapy and radiotherapy? Although this prognosis of the disease is not so good, so what kind of challenges you are facing from the patient sides and your sides as a state government or government of India? It's all because these all treatment modality is very costly and it's not so readily available. So can you say something about this?
So head and neck cancer. So regarding the radiation, even if the patient is placed for concurrent chemo radiation, so patient has to stay for a prolonged period of time. So logistic is a very much issue. So they have to come every day to take the treatment or radiation for 5 days in a week, along with every week chemotherapy. So logistically, it is very difficult for patients to manage to stay for 6 weeks to 7 weeks treatment. And talking about our perspective or our problem, yes, the nutritional is very much problematic, because head and neck cancer, the nutrition is very poor. So most of the patients present with a very poor nutritional status, and we know that it is if the patient is not nutritionally sound, that the side effect and that adverse events will be maximum in those patients. So managing that aspect, along with the some logistic problems, and all these are the main difficulties that we are facing right now in the government situation. Of course, the cost is one of the issue, but with the government PMJY card and Atal Amrit card that is available in our state, so patient can get the benefit. So the monetary problem is not very much there in many of the patients, but logistic and the nutritional support, the psychological support, mental support is very much essential and seems to be lacking in some aspects.
Okay, yeah, this is everywhere, I think so. And you have already told so much about monoclonal antibody, like nemotuzumab and all. So are you thinking this is superior or unique option to give treatment to such patients? Is there any like what is the outcome of this?
It is very much very early to say that it will be superior versus chemotherapy, because what we are getting is only the 2 year data. So we have to, in my opinion, we have to wait for a little bit more time actually. But the early results are very much encouraging. So at least we have to wait for another 3 year. Maybe they can present the 5 year overall survival data. So which will be very much encouraging for all of us. But the early trends are very good. So I must say. And regarding the cetuximab, yes, some patients are cisplatin ineligible because of the renal toxicity and other comorbidities. So cisplatin is very much toxic to the patient. So if the patient could not take the cisplatin due to some comorbidities, so we can at least use some biological in place of cisplatin. And studies have said that they have given us the equal benefit compared to the conventional chemotherapy. For those patients, so it can be one of the options. And post concurrent chemoradiation, If the patient relapses, then along with the concurrent, along with the palliative chemotherapy, we can use the biological as one of the options. So we have also used in some patients cetuximab along with some combination chemotherapy like docetaxel and carboplatin in palliative setting. We are getting very good result in some patients. So it is very much it is a promising molecule, anti-EGFR molecule, be it in hematology or cetuximab. But we cannot say that it is still superior. We have to wait for a little bit more time.
Okay. One more question, this last question.
No.
As we already discussed and you told so much about the HPV, the prognosis of HPV oropharyngeal cancer is not good compared to other oropharyngeal. So can you shower some light on immunotherapy? Is it effective?
Regarding the immunotherapy, so what we have used as a practical experiences from the practical experiences that the effect of immunotherapy in head and neck cancer is not so high. If the patient is PDL1, one test is there. That is the PDL1. We have to go for the CPS scoring, and on this, if the CPS score or the cumulative proportion score, so we have to go by that from the tumor tissue. And if it is more than 20, actually the patient is eligible to go for pembrolizumab. But the cost-wise, it is very much high, and we have used in some patients, but results we are not getting. So it is not an encouraging molecule for us, I must say. So the cost is very high. The immunotherapy, yes, it is really a good prospect for those patients, cisplatin refractory patients. So we can use as one of the options, but not as a primary upfront. I will not use as an upfront option. I will keep it as a reserve if the patient can afford, if the money is not an issue for him. And so we can reserve for that category of patients.
So finally, palliative care is very important for such patients.
Yes.
I can see Dr. Rajiv, Dr. Phatyal, ma'am, both are there. Most welcome. And sir, please ask if you.
Good evening, Dr. Sushma. Thank you for organizing this webinar. And congratulations, Dr. Kalita.
Thank you.
I remember you have also had a webinar in Delhi branch occupational health webinar platform earlier.
Yes.
And it's good to connect with you with the mainstream in Delhi and people around all across the country. The issue which is in my mind at the moment, I want to make a comment and discuss with you what is your response. Now, recently, Government of India and Assam government and Tata Memorial Hospital opened a series, a number of cancer management centers in all across various districts of Assam, and there is a plan to further develop in a number of other districts of Assam the cancer management center. Now, what are your views? Is this the right way to go about having district-wise good facility centers connected with a center of excellence in the country, and create a model for statewide development of cancer management in a comprehensive manner? What are your views on this?
Absolutely, sir. So it's a very good initiative from the Assam Cancer Care Foundation, which is also an initiative of Tata Trust and Government of Assam. So they have extended the benefits. There were some level 1, level 2, and level 3 centers. The level 3 center, they are planning to go for almost in every district, almost one center in every district, where there is some basic facilities like palliative care and radiotherapy. So these are the facilities will be available in L1 center, which is the tertiary center, where all the modalities of treatment, be it a surgical perspective or radiation or medical oncology, systemic therapy, all will be available. And in L2 center, in selected center, they will have the options of giving the radiation along with the chemotherapy also. So it's a very good, actually, so designed comprehensive cancer management, and it is needed because the logistically it is not possible for all the people to go to either Chennai or Delhi or Mumbai to take the treatment. So at least they can have there some form of treatment, whatever the patient is affordable, at least at their home, from the comfort of their home. And I would say that it is very much essential, because staying away from the home and taking treatment is very difficult for not only for the patient, but for the whole family has to suffer. So seeing this problem, and so visualizing this, the government of Assam has made some wonderful centers. So we have also visited some places. So all the facilities are very good, very much available. But manpower will be issue in recent time. So how they will manage the manpower, that will be a challenge. But it's a very good initiative, I must say, from the government of Assam.
Yes, that is exactly was in my mind. How would you create trained manpower where the expertise of appropriate level? Because you have, even if people are trained elsewhere in the country, the model that Assam is creating is nowhere available anywhere in the country. In fact, this is the first time a state has gone and invested along with Tata Trust so much that it could be the ideal model for scaling up across the country in various states in the days to come. Uh, but the challenge, of course, remains how would you get the trained manpower? But I believe the journey needs to be traveled all the same. People will learn along the way. They may have basic qualification. They may not have much experience, but they would gain experience with good oversight and teleconferencing facilities with TMH Mumbai. There should be, because I was feeling that TMH also is looking forward to this model where remote consultation for cancer control is made available in a terrain like Assam. So that I think it's very exciting for not only for India, but I feel it globally it could be biggest implementation of innovation in cancer control with a rather community-based cancer control program. Would you agree with me on this?
Yes, sir, definitely. So the creating manpower will be a challenges, but we have to create our own manpower. So at the long run, so we have to sustain and we have to create. So we have the government has initiated the fellowship program also. We are running the fellowship program in medical oncology, surgical oncology, head and neck oncology, onco anesthesia, and the pain and palliative care. These 5 branches running with uh, uh, 2-year fellowship program, so that we can have more and more trained manpower. We can train, who can give the treatment in the remotest places all over the Assam. And apart from that, we have the MCH joining in our institute, and MD radiotherapy is also the people are also joining. So hopefully in the long run, we can create our own manpower and sustain, because it's a very robust and very big concept. And in order to sustain that, we need a very big team, and especially highly skilled manpower. So we are going ahead with that perspective, and hopefully we will achieve what we are looking forward to do in our future.
Thank you, Dr. Kalita. Wish you all the best and all the success.
Thank you, sir.
Yeah.
Thank you so much.
Yeah, thank you so much. Thank you very much for you have taken such a challenging branch, and it required lots of hard work and effort. So thank you so much for the informative session, and thank you, and all the best.
Thank you,
Namaskar,
ma'am.
sir.
Thank you.
Namaskar, everyone.
Thank you. Thank you, ma'am. Thank you.